Good morning, everyone. Good morning, my chiefs. I am Dr. Ahaneko Ekene, the House Officers Representatives. For the period of this morning section, I'm going to be the moderator. So I am using this opportunity to welcome every one of us to today's series of research methodology. But before I proceed with what we have this morning, I will like the president of the Association of Resident Doctors to take the opening remarks. Then we are going to introduce our speaker for today, and we proceed with what we have for the house. Thank you everyone for joining, and it's really going to be an interesting one today, and I believe we have a lot to learn from our guest speaker. But before that, I'll make welcome Dr. Eteke Precious, the ARD president. You're welcome, sir.
Yeah, thank you so much, Dr. Ekene. I don't know whether we started with an opening prayer that wouldn't be out of place. Somebody lead us in prayer. Let's just take an opening prayer. Hello. Okay, let me just take the opening prayer and then the remark. Father, in the name of Jesus Christ, we thank you for this beautiful morning and the opportunity you granted to us in Futowere to organize this program. Good morning, everyone in this platform. It's a pleasure to have all of us joining, and I do hope that many of us Hello, can I be heard?
Yeah, we can hear you, sir.
Yeah, we can hear you.
Hello.
We can hear you.
We can hear you, sir.
Okay.
We cannot hear you.
All right. So it's my pleasure to welcome everybody. It's my pleasure to welcome everybody to this research methodology series. We believe that we are going to learn from the experts today, and it's going to be like a discussion, and not many more people will join us. For me, research is the way to go in the modern world. It doesn't matter where you go, it's a universal language that every one of us can speak. Whether you're in Nigeria, you're in the UK, you're in the US, in this modern world, if your name is typed on Google and it's not seen there, then you're on your own. And it doesn't matter where you are, it's the same language. It's the same thing that you do in Nigeria that you do in the US as far as research is concerned. So today we are going to take the first one, the study design, which is very, very important and key to research procedures. I do not have any doubt that the guest lecturer is going to do justice to this. He's a biostatistician with a lot of experience. Not just a biostatistician, he's also a doctor. So there's a difference when you have a biostatistician that is not a doctor. He may not understand, but I believe so that the examples he's going to give us today will be those things that we're aware of and we are used to. So grabbing it will not be so difficult for us. So having said this, I want to thank everyone who have logged in, those that have made it to be possible, the editor-in-chief who is on transit, the SOTAD, Dr. Ekene, who is here, and all the ESCO members who are here. You can see the IPP is also here, and other people, both doctors from FMC Futowere and outside. You are all welcome. Feel free. I know we have question section, which is going to be elaborate, and we can also all contribute. Having said this, you are welcome, and this program is hereby declared open. Thank you.
All right, thank you very much, sir, for that opening remark and the opening prayer taken by you. I would have moved forward to take more recognitions, but thank you very much because you've done justice to that as well. So welcome all my chiefs, because of time, I won't be able to start, introducing all of us one after the other. This is meant to be a 1 hour section so that it doesn't get boring. So because of that, I'm not going to waste more time in doing that, but I'm going to go straight up to introduce our speaker for today. Our speaker is one of us here in Federal University Teaching Hospital, Owerri. He is a senior resident in anesthesia here in Federal University Teaching Hospital, Owerri. He's also a biostatistician and a research advisor with over a decade experience in biostatistics and research. So he's one that we all know as someone who is exceptional in doing this, and I believe that he's going to do justice to this morning. He's no other person than the man we know as Magic Finger, Dr. Anozie Pascal. So you're welcome.
Thank you very much, Dr. Haneku, for that introduction. Good morning, everybody. I want to especially thank my president and my brother, Dr. Eteke Precious, for this honor done me today to lead the interactive session on this our research methodology series. I'm excited to be here and to be the one to steer the boat, as it were, for today's session. So without wasting more time, since we have from now till 12 o'clock to wrap up, I want to quickly share my screen. Dr. Haneku, could you please let me share my screen, please? So that we can...
I'm doing that right away, but a quick reminder, we are streaming live on YouTube, so censor everything you need to censor because we are going live as well. Thank you very much, sir.
No problem. Thank you very much for that notification. Thanks. All right. Okay, so
okay, you can
share my screen now. Yes, thank you very much. All right. Good morning one more time, everybody, and thank you for being here. Today we are going to kick off the lecture series on research methodology organized by the ABLE ESCOs headed by Dr. Eteke Precious at the Association of Resident Doctors, Federal University Teaching Hospital, Owerri. So today we are talking about, very briefly, introduction to statistics and study design. You all will agree with me that, like the president said, there's a level of relevance you should expect if you are going to be a researcher, unlike someone who is not a researcher. And whether we like it or yes, that's where everybody is looking now. So that's among other things, are the core reasons why I'm excited to be the one to take us through this morning. So we're going to use this brief outline, just a very brief introduction, then mention some of the things we should be familiar with. Most of us are familiar with them already, as we will get to find out. And we'll talk about how we conceptualize in the research process and then get to answers. Then we touch up on study design before we conclude. So it's not too much to say that statistics plays out every day in our lives. Everything we do has a connection with statistics. A lot of us are not even aware, but we are statisticians by being alive. Everything we do is actually statistics, from when you planned to attend this meeting, the things you said you're going to do before the meeting starts. Statistics is essentially about estimation, probabilities, projections. So even in the kitchen, when you're cooking, that pinch of salt you want to put, you want to estimate the one that is enough for the soup, and not going to leave the food bland, and at the same time not going to be too sharp for people not to tolerate. So, and it is also a core component of research. Like we all know, it's almost impossible, almost in the sense that you can actually write a paper and push yes, but if it's going to be seen as a research paper, there's a point somewhere in that paper that they're going to talk about statistics, because that's what research stems from, essentially. Now, the audience in this meeting, I believe, are mostly resident doctors or people who have done residency or who will want to do residency, but more importantly, who are interested in research. So, and research happens to be the second leg. That's what I call it, the second leg of the tripod that supports residency. The residency program in Nigeria and even outside the country is supported by three legs. There's the training, there's research, and then service. You come into residency to be trained in a particular specialty. As you're exposed to the training, you collect information, you give information, you gather, you play with data, essentially. And that is the place where research comes in the residency training, before you now offer service, as you do all of that. So now in the research process proper, you agree with me that in most of the researches we do, especially as resident doctors or people who did residency or will do residency, you're going to write your own research for part 2. And there's a segment they call research methodology. Research methodology will be what I call talk. You're just talking. You're not doing anything. You're just speaking, if you are not going to involve statistics. So you agree with me that to talk research, you have to talk statistics. Even if you don't like statistics, you have to interact with somebody that likes statistics or does statistics. So you can't run away, except you want to play down your relevance in the scheme of things when it comes to the world of today and the way we interact as scientists and doctors. Now, a brief on some key statistical concepts. Some of us, we already are aware, some of us know about them, but we probably need to streamline what we know about some of these concepts. But even beyond the scope of this meeting, some of the things we're going to mention or try to describe are going to form the basis for whatever we'll learn here and after here. Yeah, so because this meeting is actually not exhaustive, it's just a brief introduction of the concepts that are involved. So the first thing we want to talk about is what we know as variable. A variable it has been described in so many ways, but I like to simply call it containers for data. In the research that we do, or the ones we read about, there are things we study, and there are forms in which those things come. Those things we study come as variables. But the information we get from those things, or that we use to interact with one another in understanding those things, will be data. But where data sits in containers that we call variable is a form in which data can be uniquely identified. If you're going to study, say, for instance, whether the volume of fluid you give a preeclamptic woman matters in the outcome of the patient in terms of cardiovascular status, for example, information you're going to collect will be the volume of fluid you gave to the woman, the age of the woman. Each of this is a variable, and they are containers that are going to have some fluid in males, which is the data at the end of the day. And then a number in years, which is the data for the second variable, that is the age of the patient, as it were. So, and you can now see that it has a lot in common with data. And well, since we are already here now, it may make sense to talk about quantitative and qualitative data, which are the two broad ways that quantitative variables and qualitative variables, which are the two main ways that variables can be presented. A variable can be quantitative when it deals with numerical information, when you're talking about numbers, any number at all, especially if you're going to use it in calculations or mathematical operations. That's when you talk about quantitative variable, like the age we mentioned a while ago, the score of a person in a test. All those are quantitative variables that can now have real numbers like 10, if it's maybe the person scores 10 out of a possible 20 or 100, or 35 if the person is going to, if you're talking about the person's age. They can also be qualitative if you're describing data. For example, if you are going to talk about a patient's race, Caucasian versus an African or a Black person, that's a descriptive property of the person or the subject or the patient you're interacting with as you're doing your study. So that is not supposed to have a number as the value, but it takes the form of quality, a feature that the patient has, and you can end up interacting with it in terms of data when you count how many Black persons participated in this study. That variable is qualitative. Other things that fall into qualitative include maybe the patient's tribe, the grade of the surgeon that operated the patient, the location of the hospital where the studies were done, if it was, for instance, in a multi-center study. All these fall under qualitative variable. Then, like I said, data interacts more meaningfully when you arrange them in variables. When you want to check, for instance, in the statistical analysis that statisticians do, when you want to check if there's an association between the age somebody enters residency and how quickly they finish residency. If they are going to interact meaningfully, you're going to put one as a variable on one side and the other one as a variable on the other side before you now use the data to interact and get the answers to the questions you set out to answer. Now, some people erroneously, because of the fine details between variable and data, some people misconstrue or interchangeably use these words, but they are not exactly the same, as we'll see in the next slide. That data is actually any collection or measurements or observation, anything you measure. That when you measure something, the result of that measurement is data. You may measure something in terms of variable, but that thing you find, if you want to know the weight of a patient, you wrote on paper that what we're going to collect as information is the weight of the patient. That 79 kg that the patient weighed becomes the data that you measured or you observed. So it is any feature or entity that is capable of being ultimately described in terms of meaningful or useful information. The patient stands on that scale. You look at the needle and see it is 79 kg. You note that that has become information that is going to be relevant in the study you're doing, because you're going to record it for this person, collect for the next person, collect for the other person, and so on and so forth. Again, data in terms of how it appears can be quantitative or qualitative, just like the way the variables are the containers for quantitative variable and qualitative variable. So like I said in the example when we're discussing variable in the previous slide, if you collect a patient's age, you are likely going to have it as a number, so it will be a quantitative kind of data. If you collect if you ask a person how, maybe use a pain scoring system to assess maybe the adequacy of an analgesic agent that you gave, that person is going to, if you say they should score it on a scale of 1 to 10, that number they will pick, maybe 7, becomes data that is quantitative. But if you ask somebody who did your surgery, say a senior registrar or a consultant, or was it a procedure done by a nurse, that becomes qualitative kind of data. Now, data does not have to make sense immediately in itself. It is just data, but it doesn't have to mean anything. For instance, 21 is information, is data, but it doesn't really tell you anything. Is it 21 times that something happened, or a 21-year-old person, or number 21, something street? Or is it blue? When you say blue, are you talking about blue car or the color of somebody's eyes? The question you asked in the questionnaire that had a yes, if you just see where they wrote yes, it can be yes to anything. So, but as the yes or the blue or the 21, it stands alone as data. But it doesn't make sense until you assign it to something. For example, in the 21, it can be somebody's age. It can be age when they started smoking. It can be age when they first left Nigeria or something. So that's when it becomes useful in terms of what made you collect the data. Otherwise, data can actually be standalone, but it won't be useful for anything, even though it is still data. So they can be isolated into unique measurable units, which we called variable in the previous slides. Now, in the description of data, finally, there's something we call data types. So some of us that are already into the research sphere are very familiar with this, and I'm sure most of us here also know it, just that sometimes we kind of don't align it properly in terms of what it should be. So data can actually come as names, what we otherwise know as nominal data, or order, what we often call ordinal data, or numbers, which I've been calling numerical data as we've been talking since. So now the numbers, the third point there, which is number, have been split into two main types of numerical data, which can be continuous or discrete. Continuous means that there's no clear-cut division between a point in the data set and another point. For example, numbers can be pain scores, like I said before. Numbers can be the number of children a patient has. The pregnant woman we talked about, if we are talking about parity, we may also want to know the number of children the woman has before, which will be important in what we are studying. So if you're going to collect data about a patient and you are looking at numbers, you can ask the patient's age, which will come as a number, maybe 31 years. You can also ask the number of children the patient has. A patient can be 31 years and 6 months, which comes out as 31.5 years, but they cannot have 3.2 children. So the age becomes continuous because there's a decimal. That's the simplest way to represent it. Once there's a decimal, or there's a likelihood that the number you are getting can have a decimal, it's likely to be a continuous kind of data. But when it doesn't make sense to have decimal, like the number of children I talked about, the number of times you visited a particular state in Nigeria, that becomes discrete. There's always a sharp line dividing this information from that information, even though they are similar or they are the same variable. Then order, like I said in the second point, is order. It's ranked. There's this hierarchy. You can begin from small and climb to the bigger ones, or you can begin from the bigger ones and climb down to the smaller ones. If you're collecting information about, say, part of the things the information, your data you're collecting is about the cadre of the surgeon that did the procedure. You can have a house officer that did it, a registrar, a senior registrar, a consultant that did the surgery. That is hierarchical, where, as it were, the house officer is the lower cadre and the consultant is the highest cadre. So that's order or ordinal data. But the names are just nominal. It doesn't matter the order. It's just that you're just describing unique properties of the data you are talking about. That's name. For example, tribe, there's no tribe that is greater than the other. If the information you're getting from your patients includes where they come from or which tribe in Nigeria they come from. A person that is Fulani is Fulani. It doesn't mean that a Kanuri person is less of a person than the Igbo person or the Yoruba person. So it's just the name that uniquely separates them into tribes. Those are from this tribe, go to this side, those from the other tribe, go to the other side. So that's just what nominal data is about. Now, another concept that we should always have in mind is what we call scales of measurement. Scales of measurement refers to the nature of the data as it applies to using that information you are getting. For example, if it follows through from what we said in the previous slide, where the data can be qualitative or quantitative. It can also be numerical, that has to be either continuous or discrete. Yes. So the name, like in the previous slide where you have names, order, and numbers, you also have nominal, ordinal, and numerical. That's the splitting I did in the previous slide. That's where you now have the interval and ratio, and we're going to talk about them very briefly one after the other. Nominal is what I just said in the last slide when I was describing that it is just the name to describe that thing. If you're not going to do any math with it, and then the way the relationship, there's no relationship between this person and that person in that, when you're talking about that variable, with the fact that you're outside means you're outside, it doesn't stop the other person from being Igbo. That's nominal. And there's nothing about number except you're going to count them in terms of proportions. How many of the persons we gave this questionnaire ticked that they are Yoruba people? That's when you begin to talk about numbers and when you're discussing nominal variable. If not, we are not supposed to use nominal variable or nominal data for calculations. Now, ordinal gets a bit tricky because ordinal without explanation, if you say something is ordinal, you are most likely talking about number that you are not going to use in a calculation. For example, if they say, if you give some people a test and the highest score is the first position, the next highest score is the second position, it's just the order where you ranked them. It doesn't necessarily need to be in a calculation. However, if you're talking about the order in terms of numbers, where, for instance, in the pain score example I talked about in the previous slide, you may need to do some mathematical calculations in that one. So there's always this, you need to understand what you want to do with the information to know whether it is ordinal categorical or ordinal numerical. The detail is unfortunately beyond the scope of this session, but it's something that we can find out or maybe discuss privately on how to clearly understand what these things mean. But suffice to say that ordinal can be ordinal categorical, where in the example I gave before, if you're talking about the person that did the procedure for maybe the cesarean section or the circumcision, if we are discussing circumcision in this study, was it a nurse that did it? Was it a house officer? Was it a registrar? Was it a senior registrar? Was it a consultant? That's ordinal data, but categorical, because there's nothing calculating anything in that one. But if you're talking about pain scores, how painful was this? 0 means no pain at all. 10 means the worst pain ever. Then 1 becomes important when you look at 10, because 1 is smaller than 10 in terms of the intensity of the pain. So you can actually have an average pain score. So in that setting, it becomes ordinal numerical instead of ordinal categorical. Then interval and ratio are essentially numerical in themselves. But the important difference is that even though you can categorize them, because they are categorized here is used in terms of the quantities, as you advance in, one is bigger than the other. That's the category I mean, not that they are categorical data or variable in themselves. No, they can be categorized because interval, scale, are numbers. If you studied 10 persons and you collected information that included their age, it's likely that they will not all be the same age. Some will be older than others. That's the categorization I mean. So there's an oldest person, there's a youngest person, and then there are people in between. That's categorizing and ranking. And they are also evenly spaced. And for interval, you are going to have no absolute zero. There's no, the zero can be found anywhere. It's not, there's no dead end zero. Like the example that is there, degrees Celsius, we've heard about in our environments, we can measure temperature to the tune of 35 degrees, 40 degrees. Yet in some places, you can measure temperature as in Celsius here now, or Fahrenheit. You can go as low as 0 and still go to to -3 degrees Celsius. That is an example of an interval scale. That is when you talk about scales of measurement, or you're discussing interval scale. But ratio scale, ratio is when, just like in mathematics, if you're talking about ratio, you can actually hit a real zero. Like if you're dividing something with 0, you're going to get a 0, or you're multiplying something by 0, you're going to get a 0. You're not going to get any entity at all. So even though they are numbers too, and they can be categorized, they can be ranked and evenly spaced, you can actually get an absolute 0 where there's nothing that you will find at that point on that scale of that measurement. And the typical example that we commonly use is the Kelvin temperature, because the 0 point on the scale, on the Kelvin scale, is the point where there's no thermal activity at all. Everything is fixed. So the temperature there will be 0 as it's 0. Unlike in the interval scale, where you can have minus 32 degrees Fahrenheit, that is actually equivalent to 0 degrees Celsius. Yet you can still have less than 0 degrees Celsius, like minus 10 degrees Celsius, which is an interval ratio. Then we talk about the things we study and how we study them. We look at population. Population here refers to the entire entities that you are studying. When you're doing a study, you're usually interacting with a set of things or a set of persons, or in most times in their clinical settings, a set of human beings or patients. So the things we do when we are studying, when we are doing a research that involves humans, are going to involve populations, but usually the populations are too big for us to reach. If you were studying, for instance, in the preeclampsia example, the effect of a particular drug on the blood pressure control of preeclamptic women in Owerri. Preeclamptic women in Owerri will include women who are pregnant after and their GAs maybe to my ONG friends here will help me. I hope it's still after 20 weeks. But if you're going to get information to study these people, you cannot easily reach out to all the pregnant women that could be preeclamptic in Owerri within the time you're studying. Some will not even be interested, even if you give them incentive. Some will not be interested, some will leave the town. So you will not be able to assess everybody. So populations are typically too big to be reached completely. So because of that, what we typically do is to extrapolate with the findings we get from interacting with the small group that will eventually interact with, which we'll talk about in the next slide. Then very small proportions may be studied under certain circumstances. Yes, that's because if your study, what you have said you're going to study, is limited to a small space. For example, if the title, if the work you want to do actually means, you say you want to study risk factors for low back pain among residents in surgery in Federal University Teaching Hospital Owerri, your population is surgeons in Federal University Teaching Hospital Owerri, not surgeons in Nigeria, not surgeons in Imo State, but surgeons that are employed. That study is limited to everything you're doing about it is about surgeons, not even internal medicine person, because they are doctors, but they are not surgeons. So when you limit that, the population becomes reachable, because usually you'll be able to count the number of doctors in the hospital and then extract the ones that are surgeons and limit whatever you're doing with them to those surgeons. So in such settings, yes, you can actually study the entire population if they are small enough. Then sample. We just talked about population now. Sample is a portion of a population that is under study. We said it in the previous slide that populations are so much, most times, that you won't be able to reach out to them. Then you tend to study a small group that you make efforts to represent the population as much as possible. So samples are usually studied since most population in the real world are too big. That's what I just said. And then the summaries you reach with the sample will now be extrapolated back in the population, which I talked about in the slide before this one. Samples may sometimes be the entire population for certain small study populations, like I said about the surgeons in Federal University Hospital, if that's what you're interested in, irrespective of the other doctors that are employed in that facility. So the sample, again, can be the entire population, just like the entire population can actually make up the sample that you are studying. Then there's something called sampling frame. Sampling frame is a proportion of the population where the sample will be drawn. In that preeclampsia example I gave, even though you are not going to study all the pregnant women that are preeclamptic or potentially preeclamptic inside Owerri or even Imo State, the ones that will come to the hospital may not all be studied as well. But the people who you interact with that are likely to be taken into the study make up the sampling frame. What now makes up the sample in the end is the people you finally capture based on the sampling method you choose. For example, if you are going to pick them up from clinic, it means that it is those that came for clinic on that day that you will get. If the next day is not your clinic day, but a preeclamptic patient's visit, you may not be able to assess them, but they still fall into the sampling frame because they are coming to clinic. But you miss them either because of the sampling method or the study design, you were not going to capture those ones in that your study. So, but the point here is that sampling frame is the proportion of the population where the sample may be drawn. Those people you want to collect their data, where can you find them? Even though they may be like in the preeclamptic example, it can be in the hospital setting where they come for clinic. You now pick them from wherever may be available. Then an all-inclusive sampling frame will allow for reduction in bias when carrying out research that should be reliably extrapolated to the population. What that means is that if you have to design your study in such a way that the sampling method allows for the right quality to be found in the people you pick from that sampling frame. So you have to structure it in a way that it should be when the days you collect samples should be the days that O&G runs clinic, because that's when you have preeclamptics coming, not the day internal medicine is running cardiology, because before you send the patient that has preeclampsia for cardiology to see, the obstetrician should have seen in the antenatal clinic. So you should make adjustments to capture as much as possible the people who should fall into the sampling frame for your sample to make sense, and eventually for your study and the findings to also make sense when you extrapolate to the population. The exact properties of the sample depends on the sampling frame. That's what I've been saying since, that what you're going to get depends on how you design the sample or the sampling method. So that's essentially what that line is saying. Now, from concepts to answers, when you're doing research, using residency as an example, for your part 2, there are things you expect to do. The minimum they expect from you is that you should be able to conduct a research. You're not supposed to be a superstar like our trainers always tell us. Just demonstrate that you can successfully conduct a research. So you are going to talk about why you set out to do the study. Why? That's what we tag the aim and objectives. Of course, you will have a title which should reflect what that reason for doing the study is. So you have to have why you are doing the study and the things you need to check, the purpose of doing that study, which are the objectives. These purposes are going to now metamorphose into research questions that you set out to answer. If your study is about the drug, the hypothetical drug we talked about for preeclamptics, you said, does so and so drug help control BP in preeclamptics, or does so and so drug make labetalol work better versus if you just use only labetalol? That would be the research question. So the objective can be something like to evaluate the effect of drug X on preeclamptics when compared to drug X without labetalol. That will be the objective. Then the question is, does the drug, how does the drug impact BP? Does the drug reduce BP? Or how does there's a complex way to do that, which is not part of what we're doing here, but let's talk about all those 1/3 and 2/3 research questions. So, but the point here is that for research questions from objectives, you set out what you want to do. You now turn it into a question. We want to evaluate the impact of drug X on BP control in preeclamptics. Does drug X reduce BP? Does drug X affect BP? These are forms that the questions can take. Some researches will necessarily involve hypothesis, like in this type of the example we are giving now, even though depending on what you're studying, you may not talk about hypothesis. That's why the thing is in square bracket, because it's not always, not all the studies we do, not all the researches that we do have hypothesis. But for residency, I am aware that more than 95 to 99% of any study they will permit you to do or approve for you to do in both colleges require that you test hypothesis at some point. So you may also consider that. Now, you also have to bring in statistical testing of that hypothesis if your study requires that you test hypothesis, which makes it compulsory that you collect data for you to be able to test that hypothesis and reflect the findings onto the population. Of course, when you collect data and do the statistical testing of those hypotheses, you're going to have results which you will now report to see how it reflects what goes on in the general population and compares to the other studies. So the order is you're going to have aim and objectives, and then you have research questions you need to answer. Of course, if you're going to test hypotheses, you are going to have those hypotheses, then you test them, and then using the data you collected, then have reports of the results that you're going to extrapolate into the population as your findings in the study. So having said that, how would you now decide how to go about the study? That's where the concept of study design now comes in. Study design is a big space in epidemiology and research, because there's a barrage of things you could do as somebody that is doing a study, and that for your study to actually achieve what you set out for it to achieve, you have to properly choose the structures that will make up the design. If not, you may be wasting your time, you may be wasting money, you may be putting patients' life at risk, you may be even putting yourself at risk, depending on the study you actually set out to do. So the concept of study design for researchers is absolutely important. So study design refers to the entire plan for carrying out a study. Everything you said you would do, everything, the description of that, what you said you would do, where the study will be done, why the study will be done there, when you want to do it, will it matter when you collect samples, all these things, how you intend to collect the data you're going to use, how you intend to analyze the data. When are you collecting data before an outcome happens? Are you collecting data after the outcome has happened? Are you focusing on risk factors because of all these questions? For you to answer them properly, you have to work on the study design. So it aims to transform the conceptualization, including hypothesizing, if that is part of what you're doing, to operationalization of that concept. Still on the preeclampsia example, sorry, I'm patronizing ONG, still on that preeclampsia example, if you set out to check that drug, the effect of that drug on BP control, it means that you are probably in the conceptualization, you're wondering, can this drug actually help us manage patients' blood pressure when preeclamptic patients report? You are still conceptualizing. Then whatever you're going to do to get to the point where you decide, this drug is actually not safe from what we have found. It doesn't do anything to the blood pressure. Or, yes, this drug actually helps reduce the blood pressure. That's the operationalization that you are, because you empirically tested it. That's the whole process of study design. It's important that the proposed research method fits the intended purpose of the research. A proper articulation of the study design helps us achieve that last point on this slide. Now, there are different organograms and algorithms that try to help us explain and understand study design. So, and there are some key things we have to have in mind if we are going to safely and correctly design our study and again reach meaningful conclusions that can apply to real life situation. As the investigator, you can have an experimental study design or an observational study design, depending on if you are going to just watch the patient or watch the subjects, or watch some physical events occur on their own, or if you're going to do something to the patient or on the patient and now watch for the effect. So if you're going to expose the patient to something, say back in the preeclampsia example, if you're going to give them a drug to check how it affects their BP, that would be an experimental study. If you're going to just check, if you're going to do something like impact of hypertension on the maybe ophthalmoscopy or findings on ophthalmoscopy among patients attending ophthalmology clinic in Imo State University Teaching Hospital, Olo, you are not doing anything to them. You're just checking their eyes. Just select people that are hypertensive and look into their eyes. Or you want to check people that are hypertensive versus people that are not hypertensive, then look into their eyes to see what the fundoscopy findings look like. That will be an observational study. Now, if you are going on the experimental side, if you are going to allocate them randomly, you just try to randomize the thing so that everybody stands an equal chance of being assigned into a group or another, then that will be what we commonly call a randomized controlled trial. But if you're not going to randomize them as you're assigning them to the groups, if you're studying more than one group, that will be a non-randomized trial under the experimental study design. On the observational side, if you are going to have a comparison group, remember I talked about the fundoscopy and hypertension. If that fundoscopy is only for hypertensives, you are not interested in anybody that does not have hypertension. You're just describing, you want to check their eyes and talk about what hypertension likely does to eye findings when you do ophthalmoscopy. Then you are talking about a descriptive study. But if you're going to have another group that you want to compare, those that have hypertension and those that do not have hypertension, what's their ophthalmoscopy or fundoscopy? What is it like? Then you will be doing an analytical study. Now, the point of timing as it reflects or as it affects study design talks about whether you are going to look at from exposure to outcome. Exposure here means in that ophthalmology example I gave, hypertension becomes the exposure. That is, patients who have been exposed to problems of hypertension or the disease called hypertension and the potential problems it could cause. Those are the ones that have exposure. Then if you're moving from checking those that have hypertension and then looking into their eyes, which is the incidence of maybe macular degeneration, for instance, that will be the outcome for those patients. If that is what you're doing, then we are looking at the cohort study. Because we are looking at the cohort. A cohort is a group of subjects that have something in common that describes them. In this case, the exposure, that is hypertension. A group of hypertensives, that will be the cohort. Then the outcome now becomes the macular degeneration, if that's what you're interested in. If you are looking from outcome, the macular degeneration that has already occurred, and you are checking how many of them were hypertensive actually, you are going backward to check for exposure when it comes to a relationship between exposure and outcome, then you are going to have case control studies. That's what we're talking about. Remember, we are coming from up here where we are looking at whether there's a comparison group, and the answer is yes. So that means that we are not talking about cohorts if we don't have up to 2 groups, and we are not talking about case control if we don't have up to 2 groups. If we have only 1 group, we are most likely going to be dealing with descriptive study. So kindly pay attention to what we are doing on this side, that we're actually talking about 2 groups or more, but usually we talk about 2 groups. So in the exposure to outcome, we are going to be talking about cohorts that have the exposure, in that example, hypertension, and moving toward the outcome, which is now the macular degeneration example I gave. So you're going to be talking about cohort study if you're moving from exposure to outcome. Or if you already have the outcome, you want to check those, when you did ophthalmoscopy or fundoscopy, you saw people that have macular degeneration, for example, and then you want to check backward, which of them, maybe check their records or something, which of them have, or check their blood pressure actually, which of them have hypertension. That may be what you're interested in finding out. So if you're moving toward exposure from outcome, you're going to have cases and control. That's a case control study. But if you are taking a snapshot, you're just looking at a particular point in time or a particular period in time, you are not necessarily moving from exposure to outcome, but you're looking at exposure and outcome at the same time, then you are likely talking about a cross-sectional study. That's about that. Now, some other people use something that they describe it in terms of epidemiological studies. This is how epidemiologists actually reflect their own. It is not necessarily different from what we had in the last slide, just that it's its own design. I hope this is not too small. That's why I'm trying to enlarge it so that we can see. In epidemiological study design, you can have descriptive or analytical. We saw that in the other slide. Now, under the case, the descriptive studies, what you're doing is that you're not really doing anything. You are not intervening at any point. You are just reporting what you saw. The reporting of what you saw is not what you did. It's just what, like the example I gave about maybe you did not do any procedure for the patient, that macular degeneration story and the hypertension. You want to check incidence of macular degeneration among hypertensives that attend ophthalmology clinic in Kwara State Polytechnic Health Center or something. That will be descriptive. But it can now be a case report or case series or descriptive surveys, depending on the exact thing you do when you are describing or doing a descriptive study. A case report is when you find something interesting. It's usually an accidental finding that you want to document, that you want people to be aware of. Maybe you notice that an interesting thing that is probably not a typical pattern. Say somebody dying from something that shouldn't kill the person. If you give somebody an antibiotic, it should treat infection, not kill the person, or not cause the person stroke or something. So if you find that kind of thing, you describe the patient, describe this scenario that played out, report your findings for that patient or that story. That becomes a case report. Case series is when you notice that pattern repeatedly. Like if you do this to these patients, this is what you notice. If you do the same thing to the next patient, that's what you notice. And they seem to be similar in outcomes. You now write each of those reports, reporting that pattern of events that you are seeing. That will be a case series. Descriptive surveys is similar to that. It's essentially describing what you found when you collect information from people and compare what you have found, and then you report it by just describing the findings on that report without necessarily having to intervene in any way, giving them drug or something. You are not checking the effect or impact of anything anywhere. That would be descriptive survey. Analytical, that we talked about in the other organogram that we looked at, you can have observational studies or experimental study like we talked about. This is a more similar representative of what we had in the previous slide, where the observational, similar to descriptive, is now either cross-sectional, case control, or cohort. Again, here, you are looking at that, the two-group thing we talked about, where if you are studying more than one group and you are observing them, you are doing an observational analytical type of study. So that can be cross-sectional if you're looking at a particular point in time, or case control if you're moving from the outcome to check those that probably had exposures, or cohort if you're looking at the exposures and then going forward to check who now developed outcome among those that had exposure. Experimental is the same thing we said before. If you are going to intervene at any point, if you're going to give them that drug X to see how it affects blood pressure in women that are preeclamptic, If you do it at the level of maybe a laboratory setting, that's laboratory trials. Maybe for non-clinicians, maybe all these are people that do animal studies. You check rats and give them the same drug and see what it does for them. Field trials are obviously not limited to lab events. You can do like if you do it in a hospital or maybe a multi-center study that are not limited to lab settings, that will qualify for field trials. Another important concept that we need to talk about when it comes to study design is on whether a study is prospective, retrospective, or cross-sectional. A lot of us hear this, but some still find it difficult to separate the two. It's essentially about time. If you are going to do this study and you are moving from, like in the previous slide where we had this one, if you are moving from exposure and following the patients up till a developed outcome or otherwise, that will be a prospective study. You're moving forward, you're checking. Let us watch these people that have hypertension. This woman, when did you start taking BP medicine? You note it. When did you start taking? You note for this one. You now follow them up for 2 years or 1 year or 6 months and check which of them now has hypertensive retinopathy, for instance. That will be a prospective study. Prospective studies are usually done where you are going to follow the patient up, unlike a retrospective study, where usually you are going to use records. Most of the time when you do retrospective studies, you already have the patient that has cancer, but you want to now check in time. Or you can also ask them, it's not always that you go back to records. If you want to check for the association between cancer and smoking, you can meet people that already have cancer and take history to know whether they were smoking. Or you can check through their medical records if it's maybe in a facility where there's proper documentation of patients. You look back in time in their records or ask them questions about history to know whether they had a history of smoking. That will be a retrospective study. Then a cross-sectional study, again, like we talked about in the other slide here. We talked about it here, and we also talked about it in the other slide. Will be at a given point in time or a given period in time. That one does not check backward or forward. That will be a cross-sectional type of study. Then in the hierarchy of study design, hierarchy here talks about the relevance of what is found from the study based on the type of study design. What we try to do when we do research is to find answers to questions and tender them as documented evidence of something so that we can put our feet down when we are saying that labetalol actually treats BP in pregnant women who are preeclamptic. So, but the way you get to that answer depends a lot on the study design that you used in doing that study. So, if somebody does a case report to report that labetalol actually treated or very well controlled blood pressure in a certain preeclamptic woman, that's a case report. You just stumbled on the woman's BP becoming normal suddenly, probably because you didn't know that labetalol actually treats BP. You report that. You didn't do anything special. You didn't take time to say, remove this, make sure you have this so that we can check what this is causing. So case reports are just more like anecdotal, just something we observed, and that's what we are writing. We report a case of so. That's case report. And it can help you generate hypotheses, like it's possible that labetalol actually treats hypertension, but it doesn't really tender strong evidence because so many things may have caused labetalol to apparently treat the BP in that situation or under those circumstances, because there were no regulations on what you were doing. You just reported what happened. So you can now begin to consider, is it possible that we can be using labetalol to treat hypertension? You now go to do a more structured, organized study to test that hypothesis so that we know whether we are going to be recommending that people should be getting labetalol if they are preeclamptic. Case series is the next in line in terms of body of evidence when you're looking at the hierarchy of study. Case series are stronger than case reports because, like I said when we were describing case series, it is a pattern that has been noticed. It didn't just happen to that first woman. When we did it in August, it was something like that. The September one person recorded something like that. So they keep repeating the pattern. So the evidence becomes stronger as we move down the ladder in the hierarchy of study design. And that's also how ecological studies are stronger than case series. Cross-sectional studies have stronger evidence than ecological studies. Case control studies are also stronger in that order. Cohorts, then randomized control trials, and the strongest in the list that we have here becomes systematic review and meta-analysis, which are the basis of most of the evidences that we see, especially in our textbooks. Those things that they say when they say beta adrenergic receptors are associated, they say like they are sure of what they are saying. Those evidences are found when we do systematic reviews and meta-analysis to establish, sorry, my slides went off. Systematic reviews and meta-analysis to establish causality. Establishing causality here is that what I was saying about evidence that for sure, this is what we have noticed. We even know the mechanism of action from what we have seen. So indeed, labetalol actually acts on adrenergic receptors to reduce blood pressure, according to systematic reviews and meta-analysis. So that is, in a nutshell, the hierarchy of study design in terms of evidence and how reliable we can say a study is based on the nature of the design or the report or the study that we're talking about. So in summary, I like to say that statistics is a matted tumor. It's actually a malignant tumor on the pathology that we call research. You cannot do research if you are going to abandon statistics or leave out statistics. You won't be able to talk about research if you're not going to do statistics. In the research work of conceptualizing something to reaching the answer, apparently meaningless data pieces may be turned into meaningful information if you apply the proper statistical concepts. And then understanding study design is very crucial if a safe real-life application of a study is anticipated as we live our lives as scientists. Thank you very much for staying till the end. I'll be willing to take questions from this point. Thank you very much. Hello.
Yeah, thank you so much. Thank you so much. Let the moderator take over.
All right, thank you very much, sir, for the section. I don't know if we want to type, I'll be checking up on the YouTube and see if we have some questions dropped for the speaker there as well.
So what of here? If those participating here will have questions, they can lift their hands and ask, right?
Yeah, thank you very much, sir, once again, for this wonderful statistics for research and stuff. So now we are taking questions. So while we wait for the questions, please to write the archive to take note of people who are in attendance of this meeting and as well help them do a review for subsequent research methodology. All right, so far from the YouTube channel, we do not have any question from there. I don't know here in the house if we have actually informed the House about the next series that we're going to be taking methodology. Okay, sorry, the Potad wants to say something. So you have the floor.
All right. Can I be heard?
Yes, sir, we can hear you, sir.
Can you hear me? All right. Just to say a very big thank you to the magic finger himself. You've just done justice to this. You've broken it so down that anybody can understand. Having said that, I just to contribute a bit, if you permit me, on the hierarchy of studies. Currently, we are having what we call the umbrella studies. And that umbrella study is, they are trying to bring all the systematic analysis and systematic review and meta-analysis together. All right, so when they now put it together, they also analyze it. You know what systematic review does? They review all the studies. They say randomized control studies and previous studies on that particular topic. Now, in umbrella study now, they're now bringing in systematic reviews on that topic together. That is the same systematic review that talks on a particular topic. So they now review the whole systematic reviews. They call it umbrella studies. That is the current term that is coming in vogue. I want to believe that the thing was so clear that we don't have much to talk, because what you discussed.
Hello, Mr. President, sir.
We can't hear you.
Okay, I think Mr. President is having some network issues. While we still expect him to come back, I don't know if we have any question.
I think there are some questions in the chat box. Maybe we take them.
Okay, sir, I can see them now. Okay, should I read from here or you just read and answer, sir?
Well, if I have your permission, I can read and answer them.
Okay, Potad is back.
Okay.
I can still see that his network is bad. So, sir, I think because of time.
So go ahead. If you now have questions, you can go ahead and answer them.
Okay, the first one I'm seeing here is saying, the first one I'm seeing here is saying, one of the mandates of teaching hospitals and federal medical centers is research. So the question, is there any funding for research activities in things that you'll be taking that? Then if it is something we should expect in the future, you still tell us.
Okay, yes. I got the question. The person is asking, let me open it from here. The person is saying, sorry, it disappeared. I'm looking for it. The question on whether there's any funding for research. Yes, one of the mandates of teaching hospitals and FMCs is research. Is there any funding for research activities in view of its importance? From President, yes. Unfortunately, I will say what I understand and what I know. There is, I think the funding comes from maybe what the researcher seeks to achieve with that research. For example, if it's an audit you want to do, if it's a review of a particular thing we are doing in that hospital that is going to impact on the way services are rendered within the hospital is responsible for funding such research, because usually the idea will come from typically the management. So they are going to structure the modalities in doing such research. So yes, funding can come from within the hospital, or if there's an arrangement with a third party, yes, they can be involved in funding such. But if it is something an individual wants to do, then I think it also again depends on what the person wants to study. If you want to check, if you notice a pattern in your unit where you're working, and you want to see if introducing a particular product or service makes service delivery better in your unit, you probably get ethical approval from management and the ethics committee, and then get approval to do your study, which the proposal should contain what you said you're going to do, probably including funding. So in that setting, I think you may have to fund your study or get third-party funding or grants, as it were, provided what you set out to do is clear enough to get someone to fund your study. Other than that, I think maybe somebody in the admin can explain further beyond that. But I think that if you're going to do study and it is an idea of the hospital, it is the hospital's responsibility to fund it. But if it is a private something you're doing, you are the head of department and you want to leave your department better than you found it, you can liaise with a company that is going to help fund if they accept to fund, and then you get the research done, the service is made better, and I think everybody is happy. I hope that answers the question. But if it's about residency, for example, MRTF is supposed to fund the thing we are doing according to them. So that may be the answer to that one, if the research you are talking about is your residency program. Thank you very much.
Okay, thank you, sir. I think the hand of Mr. President is up. Maybe he wants to add something.
Yes, thank you, Dr. Anozie. You said well. The person that asked that question asked specifically said, is there any such, do you have grants now in the teaching hospital? Yeah, FMC just recently turned a teaching hospital, and you know, in the universities, for it to be a teaching hospital, it means we're under a university. That is the FUTO. And I know that in the university setting, you have the TED fund. That TED fund also fund researches. Actually, in the normal climb, in the developed climes, you know that researches are not supposed to be self-funded to avoid bias. All your work as a scientist is to bring out an idea, and people are out there to fund it. That funding makes it that you don't have bias, because if you are the one to bring out money, pursue a study, and you do everything, there can be bias. You can as well manipulate the results. Okay, so your own is just to carry out the research, while some other people will fund it. At the end, you make your studies and findings available to those people and to the public. Now, while it was still a federal medical center, remember we have then the head of training and research. There is, you can as well write, if you want your proposal, let's say is so much and you can't fund it. Sometimes they don't have enough money for that. But I'm sure that sometimes if they do have, your proposal can get an attention, and some of the money can be refunded back to you to do your studies. Apart from that, you can as well seek for external grants. Whenever you have a good study, you go online. Maybe it's one of the things we are going to do in this series on how to look for fund, grant writing, and what you can do to seek for that. If you have a good proposal, There are out there people that are looking to sponsor such studies as a part in it. There's also to your proposal and dissertation. So that answers it. Thank you. Is it breaking?
Thank you, Mr. President. Thank you, sir.
All right.
Okay, thank you very much, Mr. President. I don't know if we have someone else who wants to make any further contributions on this.
Yeah, Dr. Haneku, while we wait for further contributions, I think there's another question here. So I think someone was asking about the other things that we could do. Someone is asking, do we have more deeper parts like sample size calculation and literature reviews? Yes, we do, but the details will be made known to us as we go along, and the president is going to oversee that, I believe. Yes, we do.
Okay, thank you very much, sir. Mr. President, the members of the Executive Council, my chiefs here, and my and we have to end it. Next on this series, we are going to sorry for that little disconnection. So the next on this series, we are going to be taking in introductions to sampling and sample size that are going to be taking some other things which will be made known by Mr. President. Sorry for my before we conclude. Hello, Mr. President.
Okay.
That is
thank you so much. Thank you. Hello. It's from my end.
Yeah, we can hear you now.
We can hear you, sir.
Can you hear me? Can you hear me? Okay.
Yes, sir.
All right. I want to thank immensely the speaker today again, our dear own Dr. Another Magic Finger. You've just done justice, and I believe that all of us here will have benefited from the wealth of your knowledge. I want to thank the organizers, the ESCOs, the editor-in-chief who is on transit, Dr. Ekene, and everyone who have contributed in making today's presentation a huge success. The presentation is being recorded, and also we stream live on YouTube, so we can easily download it at the appropriate time. This is just the beginning. We've had some in the past, and we're having this one today. We are going to have much more, and I believe we're going to have a larger audience. Let's believe that by this time next week, another section will also hold before then. We are going to start early for the publicity. So by tomorrow or next, the next topic will be out there. Dr. Ken, I believe that maybe by next one we can have a feedback form and evaluation. We know where and where we can get it better. Thank you so much. And let me wrap it up.
All right, thank you very much. Thank you very much.
All
I
right.
think you said it all. Thank you very much, my chief. And it's a goodbye from here this afternoon.
All right. Bye, everyone. Thank you for participating. Have a great day ahead. Bye-bye.
Thank you very much.